Outstanding, sir.
عليكم السلام.
Yes, sir.
Cyanotic neonate. Go on.
Okay. Okay, sir. So, I'm provided with frontal projection of an pediatric age group. I don't find the humeral epiphysis, so I'm suspecting it's a neonate, preterm neonate. So, in this, I can see there are multiple lines. The NG tube is seen in place with its tip at the left quadrant. Also, there's another line.
Yes.
Apart from this, I can appreciate there is some air recency under the diaphragm.
Don't worry about it.
And
Don't worry.
okay, sir, then I can appreciate there is a patchy area of consolidation identified along the right upper zone of this child.
Not patchy. Not
Yes,
patchy.
sir.
Either better to say lobar or segmental, according to site.
Yes, sir.
Means
Lobar.
laser than subsegmental, not patchy.
Yes, sir.
It's very common
Yes,
mistake
yes.
in practice, by the way. Not patchy.
Yes, sir.
See,
Yes,
lobar.
yes. Homogeneous.
See,
Yes, yes,
lobar, segmental, subsegmental. If more smaller, like round nodule, يعني larger than nodule, you can see patchy. Okay, go on.
Yes, yes, sir. So there is a lobar consolidation identified in the right upper zone. And
What else? Okay, okay. This is consultation, no problem. But what
okay,
else?
sir. Sir, I think the heart shape is
Excellent.
bit of boot shape heart shape is there with
Excellent.
elevation of the left apex of the is elevated and
Excellent.
seems to be boot shape.
Mm-hmm.
Also said the lung volume apparently is normal or
What's
this
your
no plethora like
diagnosis?
no.
What's your
There is
diagnosis?
tetralogy of Fallot.
What is tetralogy of Fallot? Tell me.
So
Component.
in tetralogy Fallot, it's a spectrum of 4 to 5 things in which there's a large BST and overriding aorta, and
What else?
also
Hmm.
four things are there in VST, overriding aorta, then more thing. Sir, ASD also sometimes related, and four
Still,
things are there.
1 second. It's still
Yes,
two important component. What happened for the
yes, sir.
pulmonary? Well, or
Yes,
tricuspid
sir.
heart? Sorry,
Yes,
pulmonary.
sir.
Tell me.
Sir, pulmonary infundibulum narrowing is there.
Okay, so
Pulmonary artery. Yes, sir.
there are
Sir, then there is a
right
yes,
ventricular
sir.
outlet obstruction, then
Yes, sir.
PSD, then
Yes,
overriding aorta and right ventricular
yes.
hypertrophy. Okay,
Hypertrophy. Yes, sir.
thank you, doctor, so much. See, my colleague, how to be sure this is valid. Look here, the apex is elevated upward due to right ventricular hypertrophy. And you must find concavity here. Why? There are very, very small pulmonary arteries. Okay, this is the aorta. Okay, and it must be here a pulmonary artery, aortopulmonary window. If there are no pulmonary artery here, it must be concave. Okay, my colleague. So this is a consolidation, maybe infection, okay, maybe edema, anything. According to the clinical, we didn't have enough data here, by the way, just cyanotic. If the patient is feverish, it may be pneumonia, but the most important here, this one, boat shape heart. Okay, my colleague, I think there are a blanket from outside. I think this is, see, it may be blanket, maybe something, we don't know. Thank you, doctor, so much. Next candidate.
Assalamualaikum.
عليكم السلام. Doctor, let's take a 5-minute break and I will come again. 5 minutes. Welcome again, my colleagues. The potential candidate, are you ready?
Assalamualaikum.
السلام.
This is the frontal half of chest and abdomen.
Give me my opportunity. I wanted to tell something. This is a newborn male patient, preterm neonate, presented with insufficient spontaneous breathing. Go on.
Yes. So endotracheal tube is low lying and located at the level of um, carina. It should be withdrawal. Um, However, I cannot appreciate a significant collapse. Mild atelectasis noted. Central venous, this umbilical venous catheter is also located at the level of T7 vertebrae. It should be at the it should also need a slight adjustment. It should be at the level of T9 to T12. Mild bilateral ground glass opacification seen with air bronchograms and mild hilar reticulations. It could represent respiratory distress syndrome. I will take the history of the patient if the patient is preterm or full term. So
Preterm.
on the basis of
Preterm.
the patient
Where
is
is this?
preterm,
See, doctor, where is this?
it is, I think, going into the portal veins.
Portal vein. Why?
Um,
Look again. See. This is artery or vein.
this is umbilical artery and going into the um, hepatic arteries
No.
or
See?
IV.
See. Portal vein or hepatic arteries will be like this. 45
Okay.
degree with vertebral column. But what structure here have a direct, yeah, a direct branch from aorta to the right and to the left?
Mesenteric vessel,
Renal artery. Okay?
renal artery.
Or maybe
Okay.
superior mesenteric, no problem. Okay. Go on.
So these both endotracheal tube as well as umbilical artery catheters are misbled. They needs urgent adjustments. I will immediately call the referring physician and also recommend urgent neonatal ICU call for adjustment of these tubes. And on the basis of these images, and the most likely diagnosis is respiratory distress syndrome. Um, I will check if there is any previous imaging available. For comparison.
Two
This
months
is
later.
previous.
2 months later. What happened?
There is marked progression noted with interstitial thickening and central lucencies.
Yes.
So it is like aggravation of the disease process, likely bronchopulmonary dysplasia.
Okay.
So I will refer the patient for
What about 1 second, doctor? What about the lung volumes? What happened?
yes, right lung volume is significantly reduced
See,
with the
this is
marked atelectatic changes as
very,
well as the
very important differential point to differentiate it from interstitial emphysema. Okay, the lung volume is reduced. And the second point, here, what happened here? Is this any bubbly appearance or lucent lines? Or this is fibrotic changes? What is the predominant process here?
I think it is pulmonary interstitial emphysema.
No, doctor, you were incorrect, but wait, I told you this is 2 months later. 2 months.
Okay.
Okay,
Yes,
and
yes, bro.
I'm just speaking. The volume is reduced. This is not
Yes,
with the emphysema. Emphysema is increased. Second, the most predominant process is fibrosis. See,
okay.
fibrosis.
Yes.
But in emphysema, it is strand-like or bubble-like lucences. Okay, so
Okay,
what's
okay.
your diagnosis?
It is respiratory distress syndrome complicated by bronchopulmonary dysplasia.
Which organ of this baby do you want to examine or to call your colleague from another specialty to examine? One specific?
CIT?
No. What is the
Uh,
cause of this dysplasia?
this cardiology workup?
No. See. Why is this what is the underlying etiology of bronchopulmonary dysplasia?
Bronchopulmonary dysplasia, I think it is more, likely due to ventilatory support.
Okay, very nice. So prolonged oxygenation. Prolonged
Prolonged.
oxygenation may cause something else, another complication.
Retrolental
And
dysplasia, I think.
excellent.
Fibrolental dysplasia.
What is the name?
Yes. It is, I think, retrolental something. I forgot the name.
Retinopathy of prematurity. Very easy.
Retinopathy. Prematurity. Yes, yes.
Okay, thank you, doctor, so much. The
Thank you.
case started with some malpositions and RDS, and then bronchopulmonary dysplasia. The volume is reduced. Next candidate. Next candidate.
We'll go to 14.
Okay.
Okay. Hello.
Hello.
I'm here.
Go on. This patient, 1 day female patient, term delivery at 14 week with fetal distress.
All right. I'm presented with X-ray of chest and abdomen of a baby, frontal projection. Here I can see the ETD tube is seen in situ. With
Are you
the
sure? 1 second. Are you sure? Tube
it
is.
is yes, it is. It should be pulled some downwards at ETD tube. I'm talking about ETD tube, which is seen at the level of the clavicles. This is an umbilical arterial catheter, which
Yes.
is seen to be displaced as it is going on the right side. Um, so it needs to be go straight in the aorta.
Hey, doctor,
Mm,
this umbilical artery or vein catheter?
it's umbilical venous catheter.
Yes, because see, this is
Yes,
the umbilical artery. This one. Look,
yes, yes.
this one.
It's very subtle downward loop. Yeah.
Where is this?
This is seen in the region of the left portal vein
Okay, in the
and
portal vein. So,
in the portal vein, yes. So it needs to be readjusted through ductus venosus into the hepatic veins and into the IVC at the level of the diaphragm.
okay. Yeah. Describe.
So
Describe
it's
it, ma'am.
likely a case of displaced umbilical venous catheter.
Okay, خلاص, the catheter, we talk about the lines. What about the chest or the abdomen? Where is the
Yes.
abnormality?
Yes, as the patient presented with respiratory distress, so I like to zoom and see the chest images. Um, in the lungs, I can see that there is mild airspace opacities in the perihilar region, more marked on the right side.
Yes, look at the lung volume. 1, 2, 3, 4, 5, 6. Is this reduced or not reduced?
It is reduced,
No,
and
no, 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 no. 6 anterior.
yes, 6 centimeters,
One, two.
so
So
it's normal,
not reduced. So
not
we
reduced.
can exclude RDS. And
Yes,
from the history, I told you it is the person. Yeah, this patient is term. It has
yes,
delivered at 14 week. Okay, 14.
okay,
Sorry, 40, 40, not 14. 50. Okay, go on.
okay. Okay, so some granular opacities are seen in the perihilar location as the patient is term.
Is
So
this is this symmetrical? This reticulation or granulation symmetrical, right like left?
asymmetrical.
Okay. So
My difference
term or
was
post-term fetus with asymmetrical,
yes,
normal or slightly increased lung volume. What it is indicate?
it indicates meconium aspiration syndrome.
And what is the complication of meconium aspiration?
The complication includes pneumothorax or
Yes,
pneumomediastinum,
yes. What else?
and
What else in the lung itself?
in the
What
lung itself, it will give areas of ear trapping and atelectasis.
Okay, it may cause also chemical pneumonitis.
Yes, and also chemical pneumonitis.
Okay, thank you, doctor. So my colleague, see, when you, this is a babygram, okay? Don't tell the examiner this is a abdominal or chest. This is a babygram. Okay.
Okay.
And when you see the patient is intubated, this is means
Mm.
that you need first to concentrate here.
Yes.
The way, in my opinion, the baby abdomen is more easier than the chest. Why? Because you either find a necrotizing enterocolitis with its
Mm.
complication or any dilatation. This or this. But here, many pathologies, including even the heart. Okay?
Okay.
Okay. Second, see, doctor, uh, this is the umbilical vein, and it looks like within umbilical vein caster, within the portal vein.
Yes.
Even you didn't see the arterial catheter by your eye, tell the examiner this is a venous catheter. Because sometimes they put one catheter, sometimes I see it before in my practice. Only one catheter, either venous, umbilicus. I don't know why
Mm.
the pediatric doctor.
Only one, yes.
Okay. And
Okay.
try to search to the other one. Look, the umbilical venous catheter is larger than the arterial. And this coil, I think from the
Yes.
outside.
Outside abdomen, yes.
Why in
Okay.
umbilical catheter artery you should go down, down? Why? Because the umbilical artery connected to the iliac, down and go up. Thank you, doctor, so much.
Thank you, doctor.
Next candidate.
Hello, doctor.
0-day male neonate has a respiratory distress and require oxygenation.
Okay. So I'm presented with a babygram of recently born neonate with respiratory distress.
Okay.
A first comment on the chest. I can see that there is bilateral ground glass appearance of both lung fields with
Okay.
air bronchogram seen in the central lung fields. There is no pleural effusions.
Okay. What's your differential?
In a newborn with respiratory distress, and I can't see the humeral epiphyses, which indicates that the baby is premature. So my
No,
first possibility is
the baby is not premature. What else?
it's not premature.
No.
Okay. So respiratory distress syndrome is one of the possibilities. However, if the baby is post-term, I can see that there are some linear streaks
What else?
within.
But see,
Yeah, it could be
one
transient
second,
tachypnea.
The predominant pathology here or process is
Yeah,
linear streaks or ground glass.
it shows ground glass
Okay,
mostly.
stop here. Okay, so go in this way. The baby is
Okay.
not preterm and there are no intubation.
Yeah. First possibility is transient tachypnea of newborn.
Okay, what history did
Uh,
you ask about?
cesarean section is
Cesarean, yes.
yeah.
Suppose it's cesarean.
So
Yes.
so this is my first possibility. Um, um, other than this, I think the heart size is normal, and there is no consolidations to suggest any
What is this?
neonatal. Uh, this is
Yes,
horizontal
yes,
fissure, but
yes.
I
Filled
think
with
it's not filled with fluid, so it's thickened, which
final
is
diagnosis. Final.
supportive of transient tachypnea of newborn. Yeah.
Thank you, doctor. It is a self-limiting. We may see
Yeah.
some lesion here or here. Nearly, it gives the same picture of respiratory disease, but the lung volume, you didn't comment on it. Very critical.
Yeah, okay.
My colleague, lung volume is the key for all chest abnormality. If it is
Okay.
reduced, you are in the side of RDS with its complication. Okay?
Mhm.
If
So it's preserved in this patient, right?
yes, if
It
preserved,
looks preserved, yeah.
are maybe tachypnea, transient tachypnea of newborn.
Okay.
If
Okay.
increased, we are talking about meconium aspiration, like this. Very critical lung volume. Okay, my
Okay.
colleague?
Doctor, I have one question. Uh, is there any humeral epiphyses? There's, or
No
how
humeral
do you?
epiphyses. No humeral
يعني-
epiphyses. And by the way, Radiopedia make a comment on this one. Okay?
Okay.
They told,
So,
see, I will show you. 1 second.
so I have to ask
Yeah, sure. See here.
about this, or it's
You
just an
may
observation?
tempted to say this is a preterm because lack of humoral ossification, but this is the
Ah,
exception that proves the rule. The child
okay.
should learn. Why?
Okay.
Because all ossification center has a range
Yeah.
between
Mm.
like 37 week and like 42 like this. This a
Mm.
range, not a definite number. Thank you, doctor, so much.
Okay. Thank you, doctor.
Next candidate.
Assalamu alaikum, sir.
Candidate 9, please proceed.
Thank you.
Okay.
Assalamu alaikum.
Salam.
So this is chest
1
X-ray
month,
APs.
1 month female baby has been admitted due to cough.
Okay.
Go on.
So this is chest X-ray frontal projection AP semi-erect view, and it shows airspace shadowing the right upper lobe. An NG tube is seen in situ with the tip in the stomach.
Mhm.
Okay, so the lung volumes are the right lung volume is slightly reduced. 1, 2, 3, 4.
Mhm.
It's slightly, there's slight mediastinal shift. Otherwise, left lung volume appears normal. There is no pleural effusion. So this is right upper lobe consolidation.
Yes.
And so there is a retrocardiac double density, like the double borders are seen on the left, especially.
This is double density. Look at it. Is this ill-defined or well-defined here?
So this is ill-defined.
Okay. So you may have some middle lobe consolidation. May. Okay.
Okay.
Because the cardiac border is obscure, but in double
Yes, sir.
cardiac border, it is very sharp. Okay. So
Yeah. Yes, sir.
what's your diagnosis, please?
So, sir, this is in. So this is right upper lobe consolidation.
Yes.
Uh,
The patient didn't have fever, but it is 1 month. Give me differential. 1 or 2 differential.
so this could be infective etiology. It could be related to heart, like congenital cardiac defect.
Heart is normal.
Okay. So, um, right upper lobe.
Yes, infective or correct. What else?
Yeah. So the visualized bones show there is some expansion at the anterior ends.
Oh, yes. Do you think it is ricket in 1 month? Very difficult.
No. No.
Very difficult.
Okay.
Oh, what's
Uh,
your final diagnosis for this one?
so
Cough
likely
containing.
infective cause.
Are you sure? The patient didn't have fever.
Patient didn't have fever, so sir, it could be okay. So it could be the congenital the lobar emphysema.
Are you sure?
Uh,
No.
no.
It is infective process. Like you said,
Uh,
trust
yeah.
yourself. Why?
So the
Because
so
the
it
patient
could be
has fever, has the
yeah.
cough, and this is for 1 month. Okay.
So it
And
could be the adenomatoid malformation.
okay, maybe. but it is, see, respect the lobar anatomy. Anyway, number one,
Yeah.
it is a mnemonic consolidation because it contains
Okay.
a program. And
Okay.
then trust in yourself. Some examiner are trying to hesitate you. Don't worry.
Yes, sir.
Okay?
Okay.
It is a lobar pneumonia. By the way,
Okay.
in neonate, many infection presented without fever, especially in the chest. Why?
Mm.
I think this is related to the immaturity of immunity like this. Okay, my colleague?
Oh, okay, sir. So
Candidate?
then, sir, antibiotic treatment. Yeah.
Yes, okay.
Okay.
Next candidate.
Thank you, sir.
Yes, sir.
Welcome.
Welcome.
One day female on high oxygenation, increased work of breathing. Okay, go on.
Okay, so I'm presented with a chest X-ray of a one-day neonate with increased respiratory effort. I can see that there are bilateral diffuse lung abnormalities in form of multiple small opacities, diffusely involving both lungs with no zonal predilection. The lung volume, I think, is preserved. Okay, so I couldn't appreciate any pneumothorax or pleural effusion. The bones appear unremarkable. So my differential for this, yes, there is NG tube in place. My differential would be meconium, aspiration. Second would be congenital infection.
Why
Would
it is the meconium aspiration? Give me two clues. List.
okay, being no reduction in the lung volumes, being bilateral diffusely involving both lungs, mottled appearance.
Okay.
Fine. The baby, no mentioning that he's preterm. So I would suggest meconium aspiration, secondly followed by congenital infection for clinical correlation, follow-up, management and follow-up.
Okay. But this lung is normal volume or hyperinflated?
It could be slightly, yes, the ribs are horizontal, yes, so it could be hyperinflated.
Okay. How we count? But look, thank you. Thank you, Dr. Nagam, so much. See, this is the anterior one, anterior segment. Two, because one is here. 2, 3, 4, 5, 6, 7. And by our eyes, this is not reduced and almost maybe hyperinflated. Number 2, asymmetrical batchy opacities. Okay. Number 3, you can ask the doctor, is this post-term? Is this preterm? Okay, ask. This is your right, by the way. He will tell you. I think I remember one of my exams. The examiner showed me one X-ray. It was a femur, and I think I didn't tell him a good opinion. What he did, he gave me MRI to help me. See, most of the examiner really are helpful. So it was meconium aspiration. Dr. Nagam, did you exclude the complication like pneumothorax, mediastinum? Hello? Hello?
Yes, I did exclude pneumothorax.
Okay, okay. Thank you so much.
Thank
Sometimes
you.
meconium aspiration cord-like opacity. Next candidate.
Assalamu alaikum, sir.
Salam. Dr. Omer,
Yes, sir. Yes.
your voice is very unique.
Thank you, sir.
Welcome, Dr. Omer. This
Thank you,
patient,
sir. Thank you.
respiratory distress at birth. Go on.
Okay, sir. I'm presented with the X-ray chest and upper abdomen of a skeletally immature patient, and in this X-ray, the obvious abnormality I can appreciate that there is inhomogeneous opacification noted involving the left hemithorax with mild contralateral mediastinal shift is also seen, and the right lung field is grossly unremarkable, and I want to know the history of the patient. It most likely is a premature patient, preterm baby, because I cannot appreciate any humeral heads, and the rest of the visualized upper abdomen and bones are grossly unremarkable. I would like to compare with previous X-ray if available, and would like to correlate my findings with the history of the patient. So it likely appears to me some infective etiology which is involving the left hemithorax
Are you
along
sure?
with underlying.
1 second, Dr. Umair. Tell me
Yes,
first about the tube.
okay, sir, lines and tubes in the lines and tubes. Mm, okay, sir, NG tube is seen curling upward, and it is likely going into the left hemithorax.
Yes,
And I cannot appreciate the left diaphragmatic contour as well. So it is likely diaphragmatic hernia, which is causing obscuration of the lung field as well.
where is the
And
stomach here?
the
Would you detect stomach?
so no, sir, no, sir. Stomach is curling upward into the left hemithorax along with the NG tube. I cannot appreciate the stomach bubble in its normal location.
So, what's your next
So, sir,
step?
it is. So next, I would like to confirm my findings with the ultrasound. I would like to perform ultrasound, and the patient also looks in the some respiratory distress. It is causing loss of lung volume and contralateral mediastinal. I will urgently pick up the phone and refer him to the emergency department.
If you didn't
And
have ultrasound, how could you confirm your
yes,
diagnosis?
sir, I could perform a contrast study, barium study. Uh,
No barium. By
no,
simple test, simple examine test or simple examination.
sir, decubitus, I don't think so. It would be
No.
any, sir,
Do you have a stethoscope?
sir, which scope? Sorry,
Stethoscope.
stethoscope. Oh, yes, yes, yes. I can
If you put
listen
the
the bowel
stethoscope
sound in
here,
the.
yes.
Yes, yes, yes. I can. Okay, 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 okay. I'll use stethoscope to have the bowel sounds in the
And by
left
the way,
hemisphere.
my colleague, I think this tube,
Mm,
I think bought as a diagnostic. Why? I
mm,
think first film was without tube, and they bought this tube to be sure this is a diaphragm.
yes.
Which type of diaphragmatic hernia do you expect this one?
Sir, there are two types, anterior and posterior, na? Morgagni and Bogdalic. I think so. It is obscuring the heart and heart border as well. So it is likely Morgagni.
Are you sure?
Sir, Morgagni is anterior and Bogdalic is posterior.
Which left
Um,
and which right?
Sir, Bogdalic is more common on the left and
Okay.
Morgagni on the right.
This is, yes, 90%
Yeah.
in the left, correct. Which is
Yes,
the
yes,
most
yes.
common? Ogdalic or
So
Mogdalic?
Bogdalic is more common and more dead harmful is Morgagni.
Is this emergency case or not?
So this is emergency case, yes,
Why? Why?
because it is, sir, because it is causing compression of the lung volume. It is
And
causing contralateral mediastinal shift,
what about this lung? It is almost
collapse.
hypoplastic.
Sir, it is
Why?
hypoplastic because of this mass effect by the hernia.
Yes, because this is in utero. Okay.
Yes,
Some
yes,
got sonarist detect this abnormality. Okay.
yes, sir, yes,
Do you know, my colleague, it is a very serious medical legal responsibility if the sonorist or the doctor didn't detect this prenatal. One of the
yes, sir.
most common problem. The patient can complain you. Thank you, doctor, so much. So please,
Thank you, sir.
my advice for all of you, when you see here multi-loculated gas containing pathology in general, have a look first at the stomach, have a look down. Can you see, detect the diaphragm or not? Is it continuous with the bowel or not? It will help you so much, my colleague, because there are wide difference between a hernia and infective process. Okay.
Yes, sir.
Okay.
Yes.
Thank you, Dr. Omer. Next
Thank you, sir. Thank you.
candidate.
All
Dr.
the candidates are done, doctor.
I think we have a long 17 candidate. All of them has a
أيوة. A few of them did not show up, and we are finished all.
okay. Any
Sir, I
candidate?
can present. Yes,
Yes.
I can present.
Okay, with pleasure. This is 9 months old male patient presented with dyspnea. Go on.
I am presented with a just radiograph of a neonate in which I can
Not
appreciate.
neonate, doctor, not neonate. 9 months.
Okay, infant. Okay, infant.
Okay.
Okay.
Okay. Now,
In which I can appreciate that there are a few patches of subsegmental consolidations in the right upper zone,
yes.
and I can appreciate slight rightward shifts of the trachea as well.
Yes. What else?
Uh,
What else?
in the left retocardiac region, there is an ill-defined radiodensity as well,
Mm-hmm.
but I'm unable to tell further about it. The rest of the lungs are normal. I would like to see this on the lateral radiograph to confirm the retocardiac capacity, whether it's present or not.
Mm-hmm.
So on the lateral radiograph, I can appreciate that there is an air lucency, which is noted anterior to the heart.
Yes.
And this is communicating with the abdominal gas shadows, and this is likely a small diaphragmatic defect through which the part of the colon seems to be herniating into the chest. So this is a small diaphragmatic defect. It's anteriorly located. So this is a diaphragmatic hernia along with a right upper lobe small
Okay.
patch of consolidation,
Could
which may be
you
secondary to
could you
infective
judge
etiology.
could you judge from the lateral? Is this herniation right or left?
Sir, this herniation, this is communicating with the colon, which is having hostration. So
We
the
have a right.
air
We have a
recency,
right.
which is
We have a
noted
right and
above.
doctor. Listen to me. We have right and left column.
Okay, sir.
This is not
Okay.
a clue. What is the clue?
Okay.
यूजफुल जिम ट्रेनर भी हो 2020 में मैंने ब्रेक की वजह
Go on, doctor. Doctor.
Hello, sir,
Yes.
can you listen me?
Yes.
Okay.
Yes. Yes.
So, sir, the stomach is below the hemidiaphragm, which I can appreciate on the lateral view as
Okay.
well.
So this is
Uh,
left. Okay.
okay,
So
okay.
is this right or left?
Sir, on frontal, it seems on the left side
Okay.
of the spine.
Okay. Okay. Sure.
So,
In the frontal, it looks like left here, and
yes,
very well when you told me this is anterior. So it is Morgagni or Bogdalic?
Morgagni. Sir, it's
Morgagni.
Morgagni hernia, small Morgagni hernia,
Thank you, doctor.
without any complication.
Thank you so much.
Thank you.
Any other candidate? Anyone
Yes.
want to take a chance?
Yes, I'm available. Thank you. Hello.
Hello, yes. I need one who didn't take a chance before.
No, I'm just random.
Okay, okay. Did you take a chance today?
No, I've not.
Okay, yeah, go on.
Okay. May I have the history or do I just go ahead?
35-year-old female with dyspnea. Go on.
Okay, so this is a frontal radiograph of a chest in a 55-year-old female with dyspnea. I
Yes.
can see a fairly rounded opacity projecting in the right mid-lung zone.
Okay.
It's silhouetting the ipsilateral cardiac border and
Then,
hemidiaphragm.
so
However, the
no.
hilar vessels,
One
sorry,
second. So tell me, this is a mediastinal or lung mass? Yani when you describe something, tell the examiner what is in your mind.
Mm.
This is mediastinal or lung mass?
I suspect that it's mediastinal.
Okay, because it is very sharp and silhouetting the mediastinal structure, especially the cardiac body. What else?
Yes, I can see that the hilar vessels are clearly seen through the
Okay.
lesion. So it's a hilar overlay sign.
So it is,
Uh,
what is
it's
indicate?
like, okay, so it indicates that it may be anterior or posterior to the
Hey, what about the
medial mediastinum.
paravertebral stripe? Is
Okay, so the paravertebral stripe is seen clearly, so it's more likely to be anterior.
okay. Look here at the periphery. Could you detect anything? This.
Yes, the
Mm-hmm.
periphery of the lesion appears somewhat calcified or high density and
Excellent.
lobulated.
Give me some differential.
Differentials include the pericardiac cysts,
Okay.
teratoma,
Okay.
um, um, a ventricular aneurysm.
Okay. What do you want to do?
To take this case further, I would correlate to the patient's history and probably recommend a CT scan.
This is a CT.
Okay, so this is an axial contrast enhanced CT scan of the
Yalla,
chest in.
what diagnosis? Tell me what is this? What's your diagnosis?
All right, I believe this is a pericardiac cyst because it's hypodense and then there's a peripheral calcification.
What else? The pericardial
It could
cyst.
be
Okay, correct. But what else? What
okay,
what
bronchogenic
other?
cyst.
Okay, what else? What other cyst?
There
Very common to have large cyst. Very common to have a peripheral calcification.
teratoma.
No,
Or
no.
okay, hydatid cyst. Sorry.
Excellent. Excellent. In my opinion, both hydatid cyst in the top when you see calcification like this, and it is large.
Okay.
By
Okay.
the way, my colleague, it is finally bronchogenic, but it is a case of differential diagnosis, both as many as possible logic differential diagnosis. Thank you, doctor, so
Yeah.
much.
Thank you. Thank you.
Okay. Anyone wanted to participate?
Yes, sir, I can take it.
Okay. Yalla, go on. Infant has cough and seizures. Go on.
All right. Okay, I'm presented with chest X-ray frontal projection of a neonate. Here I can see that there are multiple posterior rib fractures seen on the both sides.
Brilliant.
Um,
Doctor, you are
and
brilliant. Thank you. What's your diagnosis?
my diagnosis would be of non-accidental injury as the patient
You
has scissors, so I
see
will
my,
also.
thank you, thank you. See, my colleagues, the doctor smashed the case from first to second. Okay, why? Because we are in a sequence of pediatric anomaly, and I put this case like a tricky case. Okay, but I think she look it well. Okay, go on, doctor.
All right. So, as the patient has also history of seizures, so I will also request a CT scan of head to look for any underlying subdural collections or parenchymal hemorrhages. I will
Doctor,
immediately
if
alert.
you suspect a baby has a child abuse or non-accidental injury, and you do
Yes.
your X-rays and no fracture, but you are highly suspect, what do you do? What will you do?
I will do the skeletal survey.
It's
And
normal.
also,
It is normal.
okay,
What will you do?
CT scan of head.
No, I'm talking about the bone first. If you find the bone, see, if you find the bone normal and there are no neurological symptoms, you can't request the CT at all.
Okay.
What,
Then I will request follow-up X-rays after 1 week.
okay, what else?
Yeah.
Before you request, if you,
Okay.
are you a pediatric radiology or not? This is an important question. You are not in a pediatric radiology. So what is your next step?
My next step would be to consult a pediatric radiologist.
Excellent. Okay, and it is normal. What would you do?
Then I will request follow-up X-rays and the history of the patient.
Okay, but
Uh,
if we want the patient or the investigation committee will not wait for 1 week, what is the most sensitive available examination you can do to detect
bone scan, nuclear scintigraphy bone scan.
Thank you, doctor, so much. This is the usual, or this is some question related. Why we delay or follow up after 1 week? Because some fracture
Malformation.
take few days up to 1 week to appear. Why? See here, there's a callus formation or periosteal action. Okay, my colleague. This timing is very important. Let's study today the timing and the management of a child abuse because it is very important.
Yes.
Okay, my colleague, I think, according to me, to myself, this is one of the most fantastic session that conclude many and many pediatric anomalies, chest anomalies. Okay, my colleague. دكتورة نغم.
Yes, sir.
يلا another gift for you because you are doing a lot of effort.
Okay, thank you.
50-year-old female patient has some weakness.
Okay, so I'm presented with MRI of a 50 years old female presenting with weakness. I would like to have a general look before starting my comment. Would you scroll for me? I can see that there are bilateral. Okay, this is T1.
Okay.
Okay, there are bilateral perispinal abnormal lesions.
Okay.
Okay, elevating the paravertebral ligaments.
Okay.
It is low on T1. I would like to correlate with T2 to identify or to characterize these lesions. Yes, they are high on T2, so these are fluids. They are connected to the spinal foramen, raising possibility of meningocells.
Okay. Or? Okay.
اسمها lateral
meningocell. Okay.
So I'm so much concerned about NF1.
Excellent.
So I would like to complete my searching, looking for other associations. I would like to proceed for MRI of the brain, looking for neurofibromas.
Okay.
Asking about skin lesions.
Okay.
And family history, genetic screening.
Okay.
Okay. So yes, these are the lateral meningocells, pathognomonic or diagnostic.
Yes.
No other associations could be identified in this MRI of the chest regarding the adrenals, looking for pheochromocytomas.
Yes.
I couldn't appreciate any adrenal lesions on either side.
Yes.
Would like to go for the MRI of the brain, looking for absence of the or hypogenesis of the lateral wing of the sphenoid. And brain tumors. Any MRI of the brain, please.
I think we didn't have. Thank you, doctor, so much. It was a case of lateral meningocells in multiple level connected. Sure, it must be connected to the neural foramen, and it is indicate almost NF1. For differential diagnosis also, you can include other possibilities or syndromes containing meningocell, but the most common one for sure neurofibromatosis. And the rest of management, all of us know it. Thank you so much, my colleague. Let's meet tomorrow in another session. Thank you, Dr. Nagam, so much.
Thank you, Doctor, so much for you. Thank you.
Okay. Goodbye, my colleague.
Thank you so much, sir.